during surgery or after surgery. Do LVNs usually work with patients in the OR? Usually no, but yeah, there are. They do. We do. We do. There's some bedside procedures that we can help perform. And when we talk about surgical procedures, I'm talking about anytime that you receive some type of anesthesia, or even if it's a local anesthetic. When I say local anesthetic, I'm talking about like if I have a huge mole on my arm and I have to have it removed, we give some local anesthesia and we excision it out. Okay, so we nurses do participate in that process.
So local anesthesia is just like for that area?
Yeah, and I'm going to be talking about local versus general anesthesia. And if you guys can, write it down right now that you have to know those differences. So if I give, I had local anesthesia in the back of my head. Can you guys see my little coin slot?
Yeah.
Okay, so when I was like 23, 22, I had a cyst, but it got really big from like in 12-month period. It got really big to the point where you know how sometimes you lean your back of your head on the wall, and if you move around like that, well, before I would move around like that and it would be even. It so happened that I would move my head and it would be like a bump, like a little speed bump whenever I would rub my head on the wall. So it got bigger. They gave me some local anesthesia. What local anesthetic do we usually use?
Numb the area.
Lidocaine. It numbs the area, but lidocaine. Lidocaine is one of the most common ones. So they gave me some injections of lidocaine. You guys have all at one point, I think, received lidocaine in your gums. And you guys go to the dentist. They give you lidocaine, and it numbs that specific area. It blocks the receptors that sends those afferent sensory to the brain saying I'm in pain. And so they opened up my scalp. They went inside my cranium. He said it was burrowing its way inside my skull, which freaked me out.
Oh my God.
And you know, don't be this nurse, guys. When you work at the hospital, you'll see amazing things. Don't be that nurse that looks at the patient like, oh my God, like guys, come here, because that's what happened to me. And the surgeon did it to me. Because I was face down, I was awake, but it was local anesthetic. I couldn't feel anything, and I felt him messing with my head. Finally, he got out, and oh my God, I could see your brain. And that freaked me out, because what protects our brain?
The meanings.
And the meninges, yeah, the meninges. The skull, but the dura mater as well. The dura, the arachnoid, and the pia mater. That protects it, so I'm thinking, hey, I didn't see it, you know? But apparently, he says that since I always sleep on the back of my head, the tissue just burrowed its way through the skull and made a hole. So if it would have gotten any deeper, it could have actually affected me neurologically.
How long did you have it?
I had it for years, but throughout a 12-month span, it grew a lot bigger. Like I noticed it. You could see it on my shadow almost.
Wow.
And so anyway, but what he did was he called all the nurses. He called all the nurses. He goes, hold on, like, guys, you guys want to see this? And they were all around me, and I'm like, come on, man, I'm still awake.
Right.
Like, so don't be that nurse, okay? Privacy is a huge issue. One other thing, write this down. One of the most basic things that you guys can do to ease the patient's nervousness is to provide privacy. Close the curtain. Okay, that's a test question. So write that down. Providing privacy is one of the most basic things that we can do, that we can perform an intervention in order to ease the patient's nervousness. Now we're going to be talking about therapeutic communication. What happens if you have a patient that tells you, I feel like I'm going to die after the surgery? The work says that the consent states that I might not wake up from the anesthesia. What do you tell the patient? Why do you think that?
It's rare.
Not it's rare. Something along the lines of that.
Tell me, why do you?
Yeah, you guys heard of therapeutic communication. What you do is you get the last part of their statement and you ask them a question. Really, what makes you think that you're going to die about it? Okay? Why are you so scared? Or let me know more about how you feel. That's therapeutic communication, and that's usually going to be the answer to any type of situational question that you get. So write that down. Okay, therapeutic communication. Anytime a patient asks you something really weird, you don't tell them everything's going to be fine because you don't want to give them false reassurance. And also, of course, you don't want to tell them you're going to die.
Right.
Okay, so you just want to tell what makes you feel that way. You want to allow them to open up more about their feelings. Does that make sense?
Therapeutic what?
Therapeutic communication. All right, so I'm going to go based on both Chapter 2 and the PowerPoint for Chapter 2. So let's go to the first one, okay? Surgery. It's by definition the branch of medicine concerned with diseases and trauma requiring operative procedures. So either you have like a tumor. The tumor would be something medical, right? You have cancer, you have an excessive growth of tissue, and we have to go inside and remove it. Trauma. What's an example of trauma? Surgery required through trauma. A car accident, getting stabbed, getting shot. That would be an example of trauma. There's classifications of surgical procedures, and you have to know these, and they're classified on their seriousness. Okay? The first one is major. Okay, it's extensive reconstruction of or alteration in body parts. Examples include a coronary artery bypass, gastric resection. You guys know what a coronary artery bypass is? What's a coronary artery?
It's when they take a different part of the vein.
Like a cabbage? Okay. A coronary artery bypass, by definition, is when you get the... What are the coronary arteries? No, hold on. What are the coronary arteries? In the heart, right? They supply the epicardium with blood supply, right? So they're clogged up. What we do is we open up the person's chest, we remove the damaged artery, and we take one from either, usually it's the leg, and you replace it. Okay, that's a major surgery. Also, gastric resection, removing part of the stomach. And then you have minor, minimal alterations in body parts. Examples are cataracts, tooth extractions. What was the one that I had in the back of my head?
Major.
Is that major?
Yeah. Minor.
It's minor.
Oh, really?
It's minor. And I'll tell you why. Look, major is considered you're going inside the body, you're removing arteries, right? This was just a cyst. It was tissue, and it was still on top of my skull. So all they had to do was open up my scalp.
Yeah, but it goes inside.
It goes inside, but that's not the key difference. Major meaning that a good way to memorize major is usually general anesthesia, major surgery. Okay, general anesthesia is when they give you the face mask and you breathe in the solution and you fall asleep and you're out. You guys ever had that? You guys ever? That's general anesthesia. So write that down. General anesthesia is your whole body. Okay? Now for me with the cyst, I had local anesthesia. That's just a particular area.
So when delivery happens and C-section?
That's major surgery.
So which one is the anesthesia? Was it?
They give you usually a spinal block for that one, epidural. Usually you stay, it depends. I've seen, my buddy just had twins. His wife just had twins, and she had an epidural. She had a spinal anesthetic. So they put some medication in her spinal column and it numbed her up. She was awake. But in other scenarios, the mother is put under general anesthesia. They asked you. Did you have spinal or? You had spinal. Usually it's better, I think, in my opinion, to do spinal because you're awake and you can receive your child. It's very important you have that bonding experience.
But, Mr. X,
Yes.
like I had the C-section and they gave me in spinal, and after my son came out, I saw him and then I was out.
Yeah.
So what?
Did they put you out or did you?
I don't know. I was sleeping and then I woke up around 11:30 or 12 a.m. and he born at 4 o'clock. So that time period I was out. So why?
It could have been that you not passed out, but you fell asleep because of the. What are one of the most common complications of spinal anesthesia?
Heart, your respiratory. Hypotension.
Hypotension, guys. It was one of the questions today.
Yeah.
Okay, the answer was hypotension. The answer was 120 from 120 to over 80 to 110 over 68. Respirations went from 16 to 14. That's just 2 breaths, and it's still within normal. So please know that because that's going to be another question on this exam. One of the most common complications of spinal anesthesia is hypotension. Okay, please know that. All right. Another way that the surgical procedures are broken down is through urgency, whether it's elective, and that means like the patient's choice. An example would be plastic surgery. Anybody in here had plastic surgery before? Okay, there you go. Anytime you have rhinoplasty, okay, nose job, okay, or breast augmentation, or what's popular nowadays? The what? Not so much the lift, but it's the injections of that stuff, of the oils that's bad for you, by the way. Botox is another one, okay? What else is real common? That's elective. Lip augmentation, that's right. Lip augmentation, breast augmentation. So those are considered elective. Be able to identify them as that. That's right, that too. Okay, if I give you guys a list of surgical procedures, I'm going to ask you guys, is this elective? Is this emergent? Okay, we'll talk about those right now. You have urgent. Urgent, necessary for the patient's health. Example would be excision of a tumor or gallstones. But notice that urgent is still not an emergency. Okay?
So yours was more urgent, but it wasn't emergency.
Mine was a little more, actually, mine would be considered elective, the one that I had. Yeah, because it wasn't interfering with anything. I just had good insurance. So I'm like, hey, you know what, take this off. No, you know, we have a hard time doing that now because of the reform in healthcare. We can't really do that anymore. You can only go and get it done if it's interfering with your daily lives. That was back in, I was like 22 or 23, something like that. Okay? All right, so you have elective, you have urgent, and then you have emergent or emergency. It must be done immediately to save life or preserve function. Examples are control of hemorrhage. So if you got shot in the leg and you check the pedal pulses are absent, what most likely happened?
You're bleeding from the inside.
Yeah, but what did you nick? What did you sever?
The artery.
Which one? Which one? Yeah, the femoral artery. Okay, I had a patient like that come into Pomona Valley one time, and he had a bilateral GSW, gunshot wound. It came in through the lateral leg, it went out through the medial, and it went in through the other one as well. But he had both pulses were intact, and he had no crepitus, meaning when we did our assessment, the bones weren't grinding. So luckily it missed the bone, and it missed the arteries. Okay.
From both legs?
From both legs, yeah. From both legs. Please know the difference between your elective, your urgent, and your emergent or emergency. Okay, those I'm going to test you on all three of those. I'm going to ask you, the patient knows, the nurse knows that the patient has an understanding of his procedure when he identifies an appendectomy as what? Is that urgent?
It's an emergency.
Yeah.
Well,
Emergency.
mind you, I gave you a very vague classification. I spit a little bit, excuse me. But an appendectomy, guys, unless it's inflamed and unless you have peritonitis, meaning it ruptured already, it's only urgent. It's not emergent. If you have appendicitis, if it states the patient has appendicitis and their WBC count is elevated, that's emergency. We need to get it out now. Otherwise, it's just urgent. Mind you, I'm not gonna give you something that's that tricky. I'm gonna give you something a lot more basic so you guys have a basic understanding. If I tell you the patient has had a what's a good example? Okay, knee arthroplasty. You guys know what that is? Okay, what part of the body am I dealing with?
Joint.
The knee, right? It's a joint. Arthro is a joint. Plasty is what? Rhinoplasty is what? Reconstruction. So arthroplasty is reconstruction of the knee joint. There's a couple of things that you guys have to verify. First of all, as nurses, we have to verify if it's the correct leg. So write that down. Anytime you have some type of surgery with both legs or with some type of extremity, you have to verify whether it's right or left. It's important that you guys identify that. That usually has highest priority. Okay? Also, if I say a patient had knee arthroplasty due to some severe arthritis, is that elective, urgent, or emergent? Urgent. Okay, the patient's not going to die if they don't have this, but the patient does need it. My mom has had knee arthroplasty on both knees, and now she's going to have surgery on her shoulder. Again, it's urgent, but it's not an emergency. It's not life-threatening. The patient will not die if they don't have this done today. Does that make sense? Yes, if you put it off long enough, eventually it'll catch up to you. But again, the shoulder, what's going to happen? Loss of function. The same thing with the knee. You're not going to be able to walk. Are you going to die?
No.
No. That's really the fine difference between the three. Okay. The purpose, it could be a diagnostic procedure. Sometimes, you guys heard of laparoscopic procedures?
Yes.
Okay, what is a laparoscopic procedure?
Wait, look.
You go into the belly button.
Yeah, you go into the belly button, and we have this cool new technique that we make an incision in the belly button, we put a little device in there, and we pump up the stomach, the cavity, with CO2. It's horrible. And we could go in either through the vagina or through another area, and we can actually look inside what's happening. That's a diagnostic procedure. It's an example of a diagnostic procedure. Okay. So again, purpose of diagnostic to confirm, diagnose. Sometimes a patient might have lung cancer. What did Walter White have done to verify his lung cancer? You guys know who Walter White is, right? You guys don't watch Breaking Bad? You guys gotta watch that show. Anyway, Walter White, character in the show, had lung cancer. He had a bronchoscopy. The tube went inside and we did a biopsy. We removed part of that tissue so we could look at it under the microscope. See, it's diagnostic purposes. So that's a reason why we might have a surgical procedure. Ablation. You guys have to know what ablation is. It's the removal of certain tissues. Excision or removal of diseased body parts or removal of a growth or a harmful substance. You have to know that by definition as well, guys. Ablation. If you have a cancerous or a malignant neoplasm, you guys know what that is? What's a malignant neoplasm?
Means cancer.
Malignant means cancer.
That's right. Malignant means cancer. Cancerous. It's bad for you, right? Neoplasm is new growth of tissue. Neo is new. You guys ever heard of neocons? They use this in politics often. It sounds like some type of convict, right? They are. They all should be convicts. Anyway, neo, new, cons, conservatives. So new conservatives, that's what they're called. So neo is new, plasm is growth of tissue. So a neoplasm is a new growth of tissue. So if you guys ever see the patient has a malignant neoplasm, meaning it's a growth of tissue that's cancerous, that's spreading. Does that make sense? Okay, good. So that would be a surgical option for that would be ablation. We remove it. Or even if it's not malignant. Light-skinned people have a higher incidency of skin cancer because they have less cells that protect them from the sun. So they're, excuse me?
That's melanin?
Oh, melanin. Yes. That gives you the pigmentation of your skin. And so what ends up happening is at any point, if you have a new neoplasm, a new growth of tissue, we usually remove it. Okay. Now, if you don't have cancer, but you just have this new mole, is that elective, urgent, or emergent? That would be considered elective. Yeah, that would be considered elective unless otherwise specified. Okay? And then we have the word palliative. You guys have heard that word before, right?
Yes.
What's palliative?
Care.
The PQR. Oh, so what does palliative mean?
Better.
Better. Usually taking care of symptoms, okay? So if a patient has end-stage breast cancer, let's say, okay, palliative surgery would be a surgical procedure that would just make the patient feel more comfortable. Okay, or any type of cancer. I just use breast cancer because that's what came to mind. So it relieves or reduces intensity of disease, symptoms. Example, a colostomy. Does that make sense? What's a colostomy?
It's a bag for...
Yeah, it's a little bag. What we do is we sever the intestine. Okay, we sew one of it up, and we bring the other part out through a stoma or a hole in the body, and that's how you collect fecal matter or stool. You guys have seen that at the facilities, right?
Yeah.
Okay, not yet. Really? You guys gotta go. A lot of patients at your facilities will have colostomy bags or ileostomy bags. You guys know the difference between your colostomy and ileostomy bags?
Different size.
Yeah, different site, but also. When you have a colostomy, it's from the colon, or the larger part of the intestine. And if you guys remember, going back to GI, how does the stool look in the colon? It's more formed, right? So the stool will usually be a little more soft or more well-formed. Okay, write this down, guys. Make sure you guys know this. And an ileostomy, remember, that's coming straight from the stomach, right? From the stomach, it's the ileum, right? So what's the stool usually going to look like there? More loose. So if you have a patient that has a colostomy or ileostomy bag, you'll know the difference mainly by those two, by the consistency of the stool. Okay, any questions on diagnostic, ablation, or palliative? No? All right. We could also have reconstructive surgery. It restores function or appearance to traumatized or malfunctioning tissue. An example would be an internal fixation of fractures. What that means is that when you have a fracture of your leg, the bone breaks, you put some type of pins inside, and it holds the bones in place so they can fuse together after a certain amount of time. Does that make sense? Okay, so that would be an example of reconstructive. You have a transplant. It replaces malfunctioning organs or structures. An example would be a kidney or a cornea transplant. You guys know who's famous that had a kidney transplant? George Lopez. Yeah, George Lopez. And I heard he divorced his wife right afterwards. Is that true? That's awesome.
Got the kidney from his wife?
He got the kidney from his wife and then he ran with it. Yeah.
Wow.
Okay. It's life. It's what happens. What you say? All right, and then you have constructive. It restores the function of lost or reduced as a result of congenital abnormalities or anomalies. Example would be a repair of a cleft palate. Now, the main difference between your reconstructive and your constructive is that constructive, you're born with it. Cleft palate, spinal bifida, a couple of other diseases that you're born with, right? Reconstructive, meaning we're repairing something that was broken, okay, because of something that happened. Not so much congenital, meaning you were born with it. That's the main difference. I'm not going to test you on those both specifically, but just please know them, okay? And then we have a couple of phases of surgery, and please know these as well. Your before surgery, of course, your pre-operative. Your during surgery would be your intra-operative. And then your post-operative, your following surgery would be post-operative. If I talk about a patient that's in the post-operative unit, where is he at? After surgery. He's recovering from surgery, right? Pre-operative, what's happening? We're getting them ready. So what type of things do we do before surgery?
Have your sign a cassette form.
Okay, anytime the patient's going to have, write this down, guys. Anytime a patient's going to have some type of an invasive procedure, meaning we're going inside the body, whether it's a pill that they're taking to as a contrast medium, meaning sometimes people take pills or a liquid, and we take an X-ray of the stomach, and it highlights the tract of the GI tract. Patient would need a consent for that. Also, let's say the patient is like me. I got this removed. Informed consent. Okay. Another thing that we need to do as well is assess for allergies. And you guys heard of NPO?
Nothing by mom.
Why do we do NPO? Someone said it right here. Yeah, so they don't aspirate because of vomiting. So what does anesthesia do? What's the side effect of anesthesia? Nausea and vomiting. So the patient's lying down, and if the patient had a meal, first of all, they're lying flat. We give a lot of medications, anticholinergics, that reduce the secretions in the GI. So all the mechanisms that are keeping everything inside, they're relaxed right now. So the patient's supine, the likelihood of them vomiting and aspirating is very high. So please know that. It's a test question. The whole reason for an NPO, usually 12 hours before the procedure, is to prevent aspiration via vomiting.
12 hours?
Usually it's 12 hours. Yeah, usually it's 12 hours. I'm not going to have like NPO 12 hours, NPO 8 hours. I'm not going to have that. Just understand the concept. Any questions on pre, intra, or post operative? No? Okay. A couple of factors also including influencing patient outcomes. Who's going to have the best outcome of a surgical procedure? Usually the younger. Now, I'm not talking about 3 years old young. Okay, they actually fall in with that same category as the older adult. I'm talking about younger adults. Okay, usually from 18 up until the 30s, we typically do better in surgery. Okay, so that's something that you guys are going to have to know. So, age, young patients, older patients. Know the difference between the two. As you get older, we talked about older considerations for all the systems that we covered during A&P. So everything just starts breaking down, right? So just have that in mind. Physical condition. Healthy patients, coexisting health problems. If somebody has, if I have diabetes, hypertension, if I have renal issues, and then Mr. Matthew here is a young, strapping lad that's really healthy, who's going to have the higher likelihood of dying during surgery? Mr. She wants to die, man.
All right.
No, it's going to be Mr. H. Anybody with the coexisting medical issues, or anytime the patient is older, okay? And also nutritional factors. Carbohydrates and fat, they produce energy, and proteins build and repair tissue. So by knowing that, guys, anytime you have a patient that's post-op, what type of diet do you want to encourage after they can have PO substances? You want to give them high protein, make sure that their carbohydrates and their fats are included as well. Why? Because the body needs energy. Anytime the body is under any stress, whether it's psychological or physical, let's say you just had an amputation of your leg, your body's under stress, so it needs energy and it needs proteins to build up that tissue. Does that make sense? Okay, now before you give any type of medication, of diet, what do you assess? Because the patient just had general anesthesia, right? They were all numbed out. It numbs everything out. What do you assess before you give them any POs? Yeah, you assess a gag reflex. You always assess a gag reflex, okay? So write that down, please. You want to assess gag reflex prior to giving any PO administrations. PO is by mouth. What does perioperative mean? Yep, all of them. It's just like the umbrella term, perioperative. It talks about everything. So right now we're discussing perioperative procedures. To be specific, I've talked about pre, intra, and post. But perioperative is just the term that we use for the whole thing. So don't get confused. PERI. It's the headline. The headline on both three of those boxes right there. Perioperative nurse. Just talking about everything. I just don't want you guys to see that and freak out like, he didn't talk about that. Okay? Alright, psychosocial needs. This is something that I was talking about earlier before we started this. Patients tend to freak out. Okay, especially young patients. Anytime you have a patient that's young or that's really scared, you always use what, guys? What type of communication? Therapeutic. Therapeutic communication. They tell you, I think I'm going to die. You say, why do you think you're going to die? Well, because of this, and that, I got no money. Why do you have no money? I mean, you guys see where I'm going with this, right? Okay. The most squared, politically correct question, that's what you're going to ask, okay? You don't ever tell them you're going to die or nothing's going to happen to you or this. A lot of people feel like this. You don't want to dismiss their issues. So, psychosocial needs, fear of loss of control with anesthesia, fear of the unknown, the outcome, the lack of knowledge, fear of anesthesia, waking up. Are they going to, before anybody that's had surgery or has had general anesthesia, they tell you that 3-point-something% of the population doesn't wake up and they die. Not 3-point-something%, that's pretty high. But something lower than that. The fear of pain, they feel like they won't be able to control the pain. The fear of death, and that's a real, do people sometimes not come back from this?
Yes.
Yeah, sometimes they die. Okay. Fear of separation, maybe they have no support group. Fear of disruption of life patterns, ADLs. If the patient has had needs a colostomy bag, okay, what are they going to be worried about? The appearance is primary. Yeah, also they're no longer going to be like, oh, I'm going to go to the restroom, go sit down. They don't longer do that. It's like I have to go and empty out my bag and then spill it all over my body. Okay. And then fear of detection of cancer. That's a big one. And for next week, we're going to start talking about cancer. Just know now that one of the most common reasons why people don't get diagnosed with cancer until it's too late is because they're scared of going and find out that they have cancer. Okay, I think it's the same thing with like STIs or STDs. They're like, oh, I'm not going to go. I don't have it because I haven't gone and they haven't told me yet. But I have all these sores. But that's usually the big thing. I have all these lumps, I have all these masses, but it's not cancer, so I'm not going to, because you're scared of hearing cancer. All right? Any questions so far? Okay. Go to page 19 on your chapter 2, 19. It has a couple of key terms, okay? In the book, yeah. Table 2-2 on page 19, the top box. It has a couple of terms. You guys have to know all of these. Okay, because they're used in the exams. So anastomosis is the union of two parts of tissues. Okay, so like if we have a gastrectomy, a removal of the stomach, what we do is we anastomose part of that stomach with the lower intestine. We fuse them together. That's what anastomosis is. So please know what anastomosis is. Ectomy is going to be removal. Okay? Ectomy is removal. That's usually going to be the suffix. Okay? It's going to be at the end. Lysis is destruction of. Orophy, surgical repair. Oscopy, direct visualization. Ostomy, opening made to allow passage or draining, like colostomy. Otomy, opening into. Pexy is fixation, meaning when you prevent things from moving. And plasty is plastic surgery. Please know these terms, okay, guys? Please know these terms. And then we also have the common surgical settings. Inpatient, what does inpatient mean?
Interior.
Patient stays at the hospital, okay? Before this whole reform of healthcare, guys, people used to have like a simple procedure and they would stay in the hospital for like 2 days just to make sure. Nowadays, or even women that would give birth, normal delivery, they would stay in the hospital for like a day or two, for a little longer. Now, they make sure you get out real quick, okay, because it's cost effective. You have 1 day or same day surgery. You have outpatient, short stay unit, mobile surgery units. There's a lot of different definitions, guys. Please know the difference between your inpatient, your outpatient, and your 1 day surgeries. Those are really, really important. Okay? You guys got that? All right. Some other perioperative nursing. Socioeconomic and cultural needs. You guys think that those things matter?
Yes.
Well, if you didn't, you better believe. Yeah, social issues always come into play. Economic. If you have bad, the show. I always reference the show Breaking Bad, because the guy Walter White, when he passes out because he's coughing so much, and you stimulate the vagal nerve. The vagal nerve decreases your cardiac function. He passed out. So when he's on his way to the paramedic, mind you, he passed out at work, and he's on his way to the hospital, he's like, just take me home, man. I don't have the greatest insurance. So your economic status does matter. Does everybody have health insurance in here? Okay.
I don't.
Some of it do, some, okay, you don't. I don't have health insurance. Okay. If we don't have health insurance, how many times have you had like a little cold where you're like, nah, I'm not going to go because they're going to charge you an arm and a leg just for a cold? So it does affect the well-being of an individual. You go to the Mexican pharmacy off of Orange, Thorpe, and Mission, yeah, or Fairplex, wherever it's at. Admission, yeah, admission. Okay. Religious. Any religious considerations?
Yes.
Like what? JWs. No Jehovah's Witnesses in here? Okay, so Jehovah's Witnesses. You cannot infuse certain blood products, right?
No blood products.
No blood products.
The only thing that now is allowed is the cell saver. So when you're having surgery, it goes into the machine and infuses it back to you.
That's right. That's right. Autologous, meaning your own blood. You can also donate ahead of time. Okay? You can also donate ahead of time, or you can give something called plasma expanders. The plasma expanders are medications that we give through an IV solution, and it expands your plasma. It kind of gives it a bang for its buck, in other words. Okay? It maximizes its effectiveness. And of course, cultural backgrounds. We talked about Hispanic or Latin men who don't like to showcase that they're in pain. So if I'm a patient and I'm not showing pain, are you going to try to medicate me? Probably not. So that's I'm going to have more pain. Therefore, I'm going to have higher blood pressure. Therefore, more and more things are going to go on. Okay, so that's why these things are really important. Education and experience, age, life experiences, and educational level. Have you guys ever had a patient that's a nurse? Okay.
Yeah.
Were they an LVN or an RN?
RN.
Yeah. How was that?
They're actually really nice.
Good. You got lucky. How about you?
Oh, she was mad on us because she knows what we were thinking to taking care of the clients, especially CNAs.
Uh-huh.
So she was mad. Whenever we go to change her, she said, "Oh, I know what you are thinking about me."
Oh, so she was crazy.
Yeah.
and
she's 99 years old. So
Okay. Wow. Yeah,
she's
that's
in
it.
the pain. She is in the pain, really.
Wow. Okay. Usually, if you get a patient that's a nurse or some type of medical professional, in my experience, they're really hard on you. I mean, literally, while you're giving the shot, like
That's not
Make sure the
good.
bevel's up. Make sure the bevel's up. Like even an IM or a sub-Q, who cares where the bevel's at? Anyway, go on.
One of the doctors delivered at the hospital, and she was telling the nurse what medication, but that was not part of the doctor's order. So it's like, no, but this is what I want. It's like, and you know, she has, I mean, this is the nurse we work out
Yeah.
together. So she's like, yeah, but you know, like, but this is what I have ordered. So then she went to the phone herself and called the other doctor, which was her friend, and then it was legal because now that she's with her.
Yeah.
But it was, you know, hard for the nurse because she has to.
If you guys are ever a patient, guys, just make sure that they don't give you the wrong medication. Aside from that, okay, let live, okay? Anyway, preoperative assessment must include home medications in use. That's a pretty important concept. If the patient's about to have a surgical procedure, any surgical procedure, meaning we're going to cut them up a little bit, and if we don't take an accountability that they took, take into account that they took aspirin at home, what's going to happen? The patient might bleed out a little more than expected. Okay, so that's why it's important to get all home medications, prescription and over the counter. Also herbal remedies. Okay, you guys heard of cayenne peppers?
Yeah.
Okay, a lot of men take cayenne peppers. You guys know for what? For what? No. For other type of growth. For other type of growth. Usually, no. Cayenne peppers. What they do is they dilate blood vessels. So, it's effective as a ED medication, right? So you could get it like a synthesized version of cayenne peppers. Now, what happens if the patient has been taking cayenne peppers? Mind you, can you look in the drug book and find cayenne peppers? No. You can Google it. And what happens if they have angina and they come in and we're about to give, let's say, nitroglycerin. You guys know what nitroglycerin does? It also dilates the blood vessels, the coronary blood vessels. What's going to happen to this patient? Because we're going to ask him, are you on Viagra? Are you on Cialis? On anything else like that? And he's going to say no. Okay? The patient's going to bottom out. They're going to have hypotension because the blood vessels are already dilated, or at least the wrong ones. And you give this medication, the patient might bottom out. There's been instances that the patient actually dies. Okay? The patient, you always have to ask for anything, any herbal remedies, anything that you looked up online that you found that you want to, anything, guys, you want to put it down. Okay? Even if it says natural, because cayenne peppers, again, they're natural herbal remedies, but it'll get you. All right, potential impact of medications on surgical experience. We talked about that. Allergies. Allergies are very important. Okay, guys, allergies should go along with your informed consent. Anytime you give an informed consent, you ask for allergies. Okay. Let's talk about the preoperative phase. Okay, you always want to include patient and family in the. Understand this for all of them, guys. Okay, you always want to include the family with the care. If the patient is dying, we talked about the dying patient last term, right? Who do we ask if they want to participate in the care? The family. We ask the family because we're assuming that the patient is undergoing the usual theoretical stages of death and dying, so we ask the family if they can actually help. Usually preoperative is 1 or 2 days before surgery. You want to clarify preoperative and postoperative events, surgical procedures, informed consent, skin preparation. Skin preparation is a little important. I want you guys to read up on that. If a patient's very hairy, what do? Shave. You shave. Okay. If the patient's very hairy, we usually shave. Sometimes for the EKG strips, patients are very hairy. You have to shave it all down. Or just with the clippers, take it off. As much as you can. GI cleansers. Have we talked about any of those? Okay. Write down Golightly. Like go and lightly. Yeah, Golightly.
Golightly.
Yeah.
What did you guys think I said?
Golightly.
You guys didn't catch the go part? Oh, I see what you're saying. Yeah. No, you give go lightly. You give go lightly. You don't go lightly. You go heavily. But you give this fluid. Usually it's about a gallon. About a gallon.
Yeah.
How fast do you take it?
You divide it into the during the day, and then you take like about an hour or two before the procedure for
GI cleansing.
Yeah, but it's for another procedure.
Yeah, well, essentially, guys, Golightly cleanses out your bowels. It cleanses out your stomach. It cleanses out your bowels. Anytime you're going to have a procedure, a surgical procedure, or a scopy procedure, meaning either a sigmoid scope or a EGD, an esophageal gastroduodenoscopy, you want to clean everything out so there's no fecal matter in there and it won't kind of get in the way and obstruct the view. So you give them Golightly. It's a fluid. We usually give it at once, unless the doctor does specify other type of administration. But not that you sit there and you chug the whole thing down, but you drink it as fast as possible without vomiting. Also, Golightly tends to bring down the temperature on a patient because it's usually at room level or a little bit colder, and the hospitals are what, warm or cold?
Oh.
They're cold. So it brings down the patient's temperature because they have nothing in their stomach, so they have nothing to metabolize or to increase the furnace or the machine to warm up the body. Does that make sense? So a patient taking Golightly, they're susceptible to hypothermia. Does that make sense? Okay. I'm sorry, Miss Addie, you had a question?
Can we just drink that as a laxative?
No. No, it's got to be prescribed.
Oh, okay.
It's got to be prescribed. Although you know some women do, and men I'm sure, take these type of medications to cleanse themselves out and to fit into dresses. You guys know that, right? Yeah.
Where can I get that?
I had a student at my other school that I worked for that did that told us, "Oh, I do that all the time, boy." I was like, "Okay, so I gotta fit into this dress." Okay, okay, it's bad for you, so don't do it. All right, you have to consider time of surgery, area to be transferred is if applicable. Okay. Also, frequent vital signs. Now, the vital signs are important. The vital signs are important. You guys want to assess vital signs frequently, okay? And I was talking about pre-operatively, okay? So you get your base vital signs is what you're getting pre-operatively. Post-op, okay, which we'll talk about in a bit, you usually, right after surgery, every 15 minutes. Every 15 minutes you get a blood pressure. After that, every 30 minutes. After that, every hour. If the patient's stable, we send him out to the post-op unit, okay? Dressing equipment, etc. You want to assess the dressings and the equipment. You want to have the patient turn and reposition and cough and deep breathing exercises. You also want to implement that post-op. Again, the patient's general anesthetic, been under general anesthesia. Nothing's been moving around too much in the body. What are they susceptible for? Constipation, that's right. Blood clots, good. What else? What happens to the lungs? Pneumonia and atelectasis. Okay, atelectasis is collapse of the lung. Yeah, I'll spell it.
Collapse of the lung?
Yeah. Atelectasis.
What is it again?
That's collapsal of the lung. It's one of your key terms, guys. But it's a collapsal of the lung, or I think by the theoretical definition is like a not normal expansion of the lung. That's what it is. But essentially, when your lung collapses, usually through some type of blockage, it collapses within itself. It's something that happens. So when you assess breath sounds, this lung doesn't expand because it collapsed. Okay. So atelectasis is what happens when you don't have a lot of breathing going on, or the machine's doing it for you if you're under general anesthesia. So a lot of patients post-op are prone to this, atelectasis. The treatment for that is very basic. You have them cough, deep breathe exercises, and reposition them. And there's one more thing. You guys know what an incentive spirometer is?
Yeah, no, that thing that you blow.
If you guys go, that thing that you blow, that's right. You guys go to page 29. Okay. On page 29, you have a little illustration of an incentive spirometer. Now, I want you guys to write this down, but that's for post-op. This is a test question, guys. One of the most common things we can do for a patient after surgery, again, they had general anesthesia, the machine's been breathing for them. When you guys breathe, is it always the same breath, or after a few breaths do you take a deep breath? After a few breaths you take a deep breath, right, and expands the lungs. When you're under surgery, guys, we're giving you just enough to keep you living, okay, and endure the surgery. So what ends up happening afterwards, We give anticholinergics with medications that decrease the secretions in the body, and you're not moving around too much. So this is very common, atelectasis. So you give them an in-center spirometer. They get the. You guys ever had hookah?
Yeah.
You guys ever smoked a joint?
Yeah.
Cigarettes?
Yep.
I'm sure everybody at least one of those. No? Okay. For those of you that haven't, in-center spirometer is you get the tube, you put it around your mouth, around your lips, and you inhale, and usually there's a little ball or a little lever that rises as you're inhaling. You want to make sure that it's above 500 mLs, 500 mLs, okay? And the higher you go, that means the better lung function you have. So the less likelihood of what developing? Atelectasis. Okay? You guys, I'm sure everybody knows somebody that's had some type of surgery. They always give the in-center spirometers post-op. It's a little device. You put it in your mouth. You guys know what I'm talking about? Please remember that you inhale. Okay? Unlike Bill Clinton, you inhale. Okay? And you make sure that the lever or the little ball or the little whatever it is, it rises up. Okay? Above 500. I'm not going to test you on it, but yeah, above 500. You know why I say 500? A regular breath is about 500 mLs of air that goes into your lungs. That's why. Okay? I just don't remember if it's each lung or both. Okay. And of course, pain medications, PRN, are as needed. I'll give you guys a break in a little bit. Anytime a patient's going to go under surgery, Miss Addie, you talked about you being anemic. What type of anemia do you have?
Iron deficiency.
Iron deficiency. What does that mean, folks?
She
needs iron. Iron is a mineral that our body needs in order for the blood cells to be normal. Think of it. That's all you guys have to know right now. So how do you increase the iron intake? Yeah, you eat green leafy vegetables. You get it through your diet. Either you take iron supplements and stuff like that. Okay? So, if you're going to have a patient that's going to undergo surgery, wouldn't it be wise to assess their blood to see if they're anemic before you actually go and cut them up some more? And so, please make sure that we always assess the lab works, okay? We assess the lab works. We assess a variety of issues. The hemoglobin is 1. And what's the average hemoglobin, guys? 12 to 16. Mind you, for males it's a little higher, for females it's a little lower, but it doesn't go above 16. Okay? Females is up to 14, I think, something like that. Anyway, what else are you going to assess? Are you going to have a patient undergo surgery if their WBCs are elevated? No, because they have a current infection. We don't want to do that.
Right.
Okay? How about if their WBCs are low, immunocompromised? No. Okay? So keep those things in mind, all right? That's why we want to check all lab works. Also, the patient's been taking Coumadin or heparin. Did I talk about those medications yet?
Yeah.
Okay. So if the patient's taking Coumadin or heparin, they're powerful anticoagulants, right? What lab tests do we assess with Coumadin? Have I talked about this yet?
PT and INR.
Good job. All right, so PT, INR. Okay, and for your heparin? Good. Man, you guys are good. PTT. Okay. Please know this is NCLEX stuff, okay, guys? So make sure you guys know that. So you guys see the importance of assessing the lab values, right before the surgery. Also, urinalysis or UA, complete blood count, blood chemistry profile, endocrine, hepatic, renal, and cardiovascular function. You also want to assess the electrolytes. Usually during surgery, what do you lose? Blood and fluids. Well, blood, fluids. Yeah, you lose bloods and you lose fluids. When you lose fluids, where are those electrolytes? They're in the fluid, so you're losing electrolytes as well. So you want to make sure that the patient has the potassium level isn't too low. Okay. Diagnostic imaging. You want chest X-rays, electrocardiogram. It's just giving you examples, guys, of any type of diagnostic imaging that we take before a surgical procedure. Okay. We talked about informed consent. Does everybody understand the informed consent? We need that anytime we're going to have a procedure and when we go inside the patient's body. You guys know you guys ever heard of an EGD? I'm not going to write it out there because I'll probably misspell it. But an EGD is an esophageal, duodenoscopy. Okay, that means it's a tube that's going into the esophagus that can visualize the lower part of your esophagus, the stomach, and your duodenum. And it's a scope. It's a little camera that goes in there. Okay? I forgot the whole point of that. Oh, that would be considered an invasive procedure. We're going inside the patient's body. You're going to have consent. And usually with an EGD, do you guys know what type of anesthesia do we use? This one's a little tricky. It's like the and/or option. We talked about local and we talked about general, right? This one's considered conscious sedation, meaning the patient's awake and they can respond to commands, but as soon as we're done, they forget. They have amnesia. Pretty cool, right? Excuse me? A magician or something?
No,
Never mind. So anyway, usually it's called conscious sedation, guys. The patient's sedated, but he or she is awake. Okay, that's what you usually do for a bronchoscopy. All right. We want to, for informed consent, we have to make sure that we verify a couple things. If I'm giving you an informed consent, that means I'm giving you this piece of paper and you're telling me that, look, I get it, I get what's going on. Now, can I have him sign this if I just gave him 3 milligrams of morphine? No. Okay, you can't. If the patient recently received any type of opioid analgesic, they can't sign it. If the patient, you have to assess their level of alertness. So you do the whole level of consciousness. How do you assess a level of consciousness?
Ask them where they are.
So you say, Mr. Matthew, okay, do you know where you're at?
Why you are here?
No, you don't know. Do you know why you're here? So you person, place, time, and event. So person, what's your name? Place, where you at? Time, what date is it? And do you know what you're doing here? Those are the 4 questions you ask. Okay, person, place, time, and event. Okay, you guys have heard that before, right? Okay, good. All right, so we talked about information that is clear, risks have been explained, benefits identified, consequences understood, alternatives discussed, which they really never do, and ability to understand. Okay, meaning the patient speaks Tagalog, you bring in an interpreter. This patient speaks Mandarin, you do the same thing. Okay. All right, let me see. GI preparation. I talked about NPO, meaning nothing by mouth. Anytime you're going to have some type of GI procedure, usually it's NPO for 6 to 8 hours before the procedure, usually after midnight. Okay, you don't have to memorize these times specific, like 6 to 8 hours is for GI. You don't have to memorize all that. Just know that usually when we say NPO, it's after midnight. Okay, my wife had to have a blood draw for something, I forgot, and it was like they told her she couldn't have anything to eat after 9 p.m. So we were grubbing at 8:30. She's like, hurry up, I can't eat after 9. Okay. Documentation is crucial. Comfort measures to reduce patients' feelings of dryness. Okay, you guys understand what that means by dryness? Okay, usually we give medications that stop secretions, that the anticholinergics that I talked about. One of the most common medications that we use is something called atropine. Have I discussed atropine before?
No.
Okay, atropine is considered an anticholinergic. So, if you give me an anticholinergic, my saliva is going to decrease in production. The acids in my stomach are going to decrease in production. The mucus in my stomach is going to decrease in production. That's what an anticholinergic does. And it makes sense because if we're going to go into surgery, you don't want all those secretions being secreted. So you give an anticholinergic. One of the most common ones is atropine. Okay? So that's why we, like for dryness, we can give them like a little mouth swab, suck on some hard candy, things like that. Bowel cleanser, we have to give them tell them a rationale for the use. Why would we cleanse the bowels? Again.
Because you're doing a GI.
You're doing some type of GI, whether it's a skull, procedure, anything, we're going to check it out, so we don't want any fecal matter in there. Any contraindications if you're allergic to any of the contrast mediums. And we have to discuss the agents used, meaning what chemicals are we using? Are you allergic to iodine? You guys see where I'm going with this, right? Skin preparations. We talked about removal of hair. We always assess for skin impairment, meaning if the patient has some type of skin tears. I don't have to go over this stuff. You guys know that, right? Okay. Scrub with antiseptic solution applied. All right, cool. If you guys go to page, Okay, page 27. Okay. This is how you prep a patient depending on what we're going to do to them. So, if the woman is, because this shows a woman here, okay? If the woman is giving birth and she's going to have an episiotomy. You guys know what an episiotomy is? Okay. How do you spell it? I don't know how to spell it. Is it I or Y? I think it's I. What does Tommy mean? Otomy. Hole, right? Opening, right? Okay, good. So episiotomy, guys, is when I'm not going to draw it out because it'll probably look bad, but essentially the woman's giving birth, you hit the vaginal canal, the head's usually, we're anticipating that the head of the child is a bit large, so we make an incision, okay, and through the perineum of the femur, in between the vagina and the anus, and we usually do a lateral cut. That's an episiotomy. Okay, which of these skin prep positions are we going to put the patient in? C. Yeah, C. The patient's going to be in the lithotomy position, and we're going to be exposing that area. We're going to put drapes and all that good stuff to provide privacy, but that's how we're going to do it. Okay? You guys understand that if a patient is going to have a procedure that's literally in this area, let's say they have an excision of a little cyst, you know that they're going to cleanse this whole area. You guys are aware of that, right? Okay. And so essentially, guys, that's what that's explaining. Okay? All right. Anybody allergic to latex? Okay. I'm allergic to latex. My hands, if I use latex literally for like a minute and I take them off, my hands will start. They're a little red right now. You guys see them? Are they red?
No.
No? Okay. Oh, no, not that much. Not that much. My knuckles get red. They're very sensitive, especially to latex and with the powder as well. If you guys are allergic to latex, don't use latex gloves. You use the synthetic ones. Okay, we have those. Okay, increased incidence of latex allergies presenting in the healthcare environment. We have different categories. Some people are allergic to latex gloves, but are they allergic to latex condoms? A lot of people aren't. But you have the different people, the people that are allergic to latex gloves and latex condoms as well. So you have different categories. You have to identify risk factors, tell them about it, and nursing interventions to reduce the risk of latex-sensitive patient. How do you do that? How do you decrease the risk? You use non-latex gloves. That's it. That's the $100 question. That's it. Okay. All right, you guys want to go on a little break? Okay, go on a little 10-minute break. Come back at 2:10. Yeah, so incentive spirometry. Yeah, when you use this incentive spirometer, guys, when do you have the patient start utilizing it? It's mostly given post-op, right? But I want you guys to understand that you start giving it to the patient, or you encourage the patient to do it even before surgery, all right, pre-op, because it's like you're exercising the lungs at its max capacity right before you go into surgery. So you're kind of working them out ahead of time as well. Okay, so you use the incentive spirometer before surgery as well. Most of the times you'll see the patients post-op, but you always start it. You can start it. You will start it before surgery as well. Is that understood? Also, when you're, do you inhale or exhale? Inhale. For how long? Usually for about 8 to 10 seconds. That's going to be the magic number that you guys are looking for. 8 to 10 seconds, but for a prolonged period of time, as long as the little ball goes up. Sometimes patients post-op, they can only inhale it for like a second or two, and then they're just fatigued afterwards. But the whole goal is to work your way up. You have them hold it for how long? 8 to 10 seconds. All right, good. Again, it's used to prevent or treat atelectasis, and we know what atelectasis is, right? Collapse of the lung, improve lung expansion, improve oxygenation. Also, an effective means of preventing atelectasis, guys, is turning, repositioning, cough, and deep breathe exercises. So that's something that you want to encourage the patient to do as well. To deep breathe and to cough, and you can do that before surgery as well. Okay. Also, you teach them this before surgery, because post-surgery, are they going to be able to understand this?
Not at first. Not
at first, right? So you have to spend more time telling them after surgery how to do it. Okay, it's also going to get in the way. So you teach them beforehand, and you have it ready for them. You teach them how to do it, and again, 8 to 10 seconds. All right, 2 or 3 deep breaths. cough 2 or 3 times, and you want to splint the abdomen if needed. You guys know what that means? Yeah, you get a pillow and you hold it over the stomach. Usually if you have an abdominal incision, if you cough or you deep breathe, your stomach expands and you'll have that dehiscence that I spoke about. We'll talk about that again in a bit. Contraindicated for surgeries involving intracranial, eye, ear, nose, throat, and spinal area. So if a patient had any of those type of surgeries, you do not want to have them cough. Okay, because when you cough, you guys ever heard of ICP? Not Insane Clown Posse, but I don't like them, I just happen to know them.
You don't like that?
No, my God, no. ICP, guys, is intracranial pressure. So if you had some type of craniotomy or something to do with your skull, what happens after surgery to the tissue?
Swells.
It swells up, right? So now if your brain is swollen up a little bit and you start coughing, it's going to increase that pressure. Same thing with the ocular pressure. Any type of eye, ear, or throat surgery, you don't want to do it. It's contraindicated. So please keep that in mind. Same thing with spinal surgery. Okay? Does that make sense? All right. Put a star next to that. Please know that. All right. Cardiovascular considerations. You want to give the patient their medications, if any. Okay? If they have antihypertensive medications, you give it to them, unless contraindicated by the physician. Also, you have a lot of issues, and this is where you're going to meet the most common complications, guys, of surgery, especially when you have general anesthesia. Again, I want you guys to think general anesthesia, nothing's moving around. You guys know what venous stasis means? Yeah, your blood essentially pools. So you have something called venous stasis. Okay, this is like it's staying still. So the flow in the veins, remember we got those chambers that I spoke about during A&P, I don't know if you guys remember. But the blood's going in. Mind you, we have a lot of, mostly when it comes to the circulation of the veins, it happens because of your muscle contractions, right? But you're under general anesthesia for a certain amount of time, an hour or 2, 6 hours. Surgeries last a long time sometimes. The blood tends to start pooling, okay? And when the blood pools, theoretically speaking, what happens? Pooling, like a pool, it all stays there together. What happens? Blood clot, yeah. So, a thrombus is another word, okay? A thrombus, okay? That's a clot. And then when you have one and it becomes inflamed, it's called phlebitis. Yeah. Thrombophlebitis. Please write this word down, folks. It comes out on the exam. Okay, I don't want you guys to raise your hand and let Mr. H, what does this mean? I'm like, Okay, I told you what it means. So thrombophlebitis. Just remember, itis is inflammation. Thrombo, there's clot. So this is when you have a clot. Usually, where do you get your clots? Post-op patients. Where do they get them?
Legs.
Yeah, legs. You guys know what tool we use to assess to see if they have a clot in their calf?
You have a venous Doppler thingy or...
We have something called you guys really don't know. Yeah. That's it. Yeah, a positive Hohenstein. Let me explain what a positive Hohenstein is. Again, because I know I explained it like in first term, but it's okay. A patient has post-op general anesthesia. They develop venous stasis. You suspect thrombus, okay? You assess for thrombophlebitis, meaning inflammation of the clot. You assess the calf, you touch it. You don't really palpate it, you just kind of superficially touch it. There's a couple of signs and symptoms. It's going to be hot, okay? It's going to be hot. It's going to be painful, okay? And also, when you ask the patient to flex their foot or to make their toes point their face, they have severe pain in their calf. That's a positive Hohenstein. Now, is this positive for a blood clot?
Yes.
No.
No, it's that they had one.
No. No, it just means that they have the signs. They have a positive Hohenstein. Okay, that's all it means. How do we assess? How do we verify that there's a clot there? Someone said it earlier.
Venus, the X-ray thing, yeah, the Doppler thing.
The Doppler. Okay? That's how we assess. The Doppler is a little ultrasound machine that the ultrasound tech comes in. He or she, usually she, attractive usually. They come in and they actually assess it in the patient's calf. It's positive, and that's how we identify it. Okay. What do you absolutely never do to a patient with a thrombophlebitis?
Don't
Make them walk away.
Their legs.
You do not massage their legs. You never rub that calf because you're going to dislodge that blood clot. Imagine if you had a little blood clot right here. Okay, and here you come thinking you're a cool nurse. I'll massage this patient. And you start rubbing it, you're going to dislodge that clot, and now you're moving a little bit more. The blood's going to keep circulating and it's going to get lodged up in your lungs. And you're going to develop a pulmonary embolism. You guys know what a pulmonary embolism is? Okay, it's a clot in your lungs, also known as a PE. Okay, it's a pulmonary embolism. Okay. A pulmonary embolism is a clot in your lungs. It gets lodged up in the capillaries. And so now you have a blood clot in the place of your body and where it's vital for you to, that's how you get all your oxygen, right? So what's going to happen to this patient? They're going to die if we don't take care of it. Yeah, they're going to die. So they're going to have a couple of clinical manifestations. In the book it outlines it. I don't remember exactly where, but let me talk about it. Okay? Think of the pulmonary embolism as a blockage to your respiratory tract. So you're going to have shortness of breath, acute chest pain, and you're going to have one more thing called hemoptysis. Okay? You're going to have hemoptysis. You guys know what hemoptysis is? Okay? Hemoptysis, hemo is what? Blood, right? Okay, so it's essentially it's when you're coughing out bloody, frothy, bloody sputum. Okay, that's usually a clear indication of a pulmonary embolism. Please be able to identify these terms, okay? Okay, they're all in the book. I just don't remember where, but they're all in there. Write them down in your PowerPoint, and as you guys go through at home, because I know you guys are going to read every single day, right? Okay. A pulmonary embolism, think pulmonary lungs, embolism as a clot. Okay? It's a clot that's lodged up in your lungs. Okay, I told you I had a girlfriend, her dad had a heart attack or something. Oh, he had surgery, that's what it was. He had surgery, and right before we discharge a patient home, one of the best ways to avoid all these things, or actually not before we send them home, but post-op, is we ambulate patients. Write that down. One of the most easiest ways to prevent this right here, blood clots, is ambulation. Usually post-op, we have the patient ambulate as best they can. Okay? I'll get to my whole story. I just want to talk about all these things because they're all going to be on the test. So again, ambulation is one of the first things that we do. Ambulation, walking. Ambulation is one of the first things that we do to prevent blood clot, usually post-op. Also, if we talked about giving anticholinergics, right? That medication atropine that stops the secretions, right? So if the patient's been lying down in bed for a long time, what happens when you get up real quick? What are you at risk for? Orthostatic hypotension, right? So what's something that you're going to do for a patient that just had surgery? Before you sit them up and have them walking around, what are you going to do? So you're going to set them up on the bed and let them dangle their legs. It sounds very basic. It sounds like we're not getting paid to do this stuff, but we are, because this is going to allow the body to acclimate or to get used to the body now being in an upright position. Okay. So again, ambulation, the first treatment for preventing a thrombus, and we actually have a patient sit up and dangle their legs so we can prevent orthostatic hypotension. Make sense? So anyway, so this girlfriend of mine, her dad went in for some surgery, and right before he got out, they had him ambulate one more time around the whole facility just to make sure that he was okay. So he was done, and he's big Mexican dude with a big old mustache, and he always has his sombrero. I would imagine he would have his sombrero at the hospital too. And right when he goes into the door, he collapses. Okay? He had a pulmonary embolism right then and there. He had a clot. In this case, the ambulation caused that clot to travel up to his lungs, and he almost died. He coded. And they gave him some clot busting medication, or thrombolytic medication that actually dissolves the blood clot. but he almost died. So pulmonary embolism is really dangerous, guys. Yeah.
If they have medication like that, then why did they put patients on like Coumadin and stuff like that when they're in the hospital?
If they had medications like what?
The clot busting one.
Well, because we can't, again, there has to be a clot in order for us to utilize it, right? So, we give them Coumadin to prevent the clotting. That's why the patient's always on a continuous regimen of Coumadin or heparin, depending on what they're on, and we make sure it's within a therapeutic level. Now, if the patient does develop a clot, then we give them the thrombolytic medications.
Well, because my mom had blood clots in her legs and they had her on Coumadin, but they didn't give her.
Because it's on the leg. Because it's on the leg. So what we usually do.
Those medications don't work.
No, they do work, but
Who's asking?
no, I get it. The reason she's asking is because we can give the thrombolytic medications, the clot busters, to get rid of the clots, right? But we still have to give the patient the Coumadin, because what's happening is their ability to clot is not working normally. So that's why we give them Coumadin. You give clot busters, for emergent cases, strokes or PEs. Usually for the calves, we could take those. We could take care of those other ways.
Did they have to stay on blood thinners?
Yeah, they have to stay on blood thinners. Like her dad, my girlfriend's. Well, she's not my girlfriend anymore, but her dad, he was on Coumadin forever. I think he's still alive. I don't know. So yeah. Anyway, those are some of your cardiovascular considerations. Okay, guys. You can do leg exercises, but again, guys, you don't massage. You can also give something called Ted hose stockings. Okay, they're like long socks with a little hole in the toe, so you can still assess capillary refill, make sure the circulation is adequate. And what that does is it provides pressure, because again, if you provide pressure, okay, it's pushing the blood through the vein. So it's actually helping with the circulation. Does that make sense? Yeah. Vital signs. You want to, before that, anti-embolism stockings are called TEDs. And then sequential compression devices. The sequential compression devices, think of them as like these casts, these synthetic. They're made out of cloth. And what happens is they get full of air and then they deflate. So it's constantly constricting and then relaxing the pressure on your legs, so it can actually provide that You're mimicking like ambulation and stuff like that. So it can actually perfuse to the vein. Does that make sense? All right, cool. Let's see, vital signs. You always want to assess BP, temp, pulse, respirations. Frequency depends on hospital and the physician. Different hospitals have different policies. Of course, the sicker the patient is, the more often we're going to be assessing them. Okay, and today you guys had a good question on your exam. It said, which of the following would you alert, or would you expect to see, or would you report for a patient that had spinal anesthesia or an epidural? What was the answer?
Blood pressure.
It was blood pressure.
110 by 68.
By 68, yeah, because the respirations, it said the temperature, it was still within normal. The heart rate, it was still within normal. The respirations, I know that's the first thing you guys went for, right? Because respirations. But it went from 16, which is relatively low, to 14, but it's still, if it would have went from 20 to 14, now we're in trouble, because it went through a long distance, right? It changed dramatically. But respiration from 16 to 14, that's okay. It's still within normal. If it went from 16 to 12, you would start looking at that. But now the blood pressure, and also in the book it tells you hypotension, and I spoke about that as well. It went from 120 over 80 to 100 over 68.
110 over 60.
Or was it 110 or 100? 110 over 68. That was the answer, because of your 68. Okay, that went significantly low. All right. Genital urinary concerns. You guys know what that is? Genitals and the urinary system. I can go over all these things, guys, but let me just talk about the very basic things of the genital urinary. You're going to be assessing for urinary retention. Okay, let me give you some signs and symptoms. If the patient just had surgery, okay, they're coming back from surgery, and you notice that they're Foley bagged, if they have a Foley bag, what's the amount of urine that you're expecting to see? At least what?
30.
At least 30 mLs per hour, right? If a patient doesn't have a Foley catheter, what happens is you see them continuously use the urinal, but they have just a little bit of amount of urine coming out, but they continuously use it. That's retention. They feel like they have to go, and they continuously go, but they dribble, just a little bit. Those are your clinical manifestations of urinary retention. Please be able to identify them. Okay, frequent urination, small volumes, that's urinary retention. Also, you can palpate the bladder. If the bladder is distended, okay, if you push down right here, you can feel it in the suprapubic area. Okay, and the patient facial grimaces, that means they're retaining urine. Usually the blood pressure goes up as well.
It's a urine infection.
Urinary retention. They're retaining. They're not getting rid of the urine. Usually because of some type of constrictor or something's pinching the urethra, or because of all the medications and the anesthesia, they've not recovered their full function to void yet or to urinate. Does that make sense? Okay. If the patient does have that, a urinary catheter can be placed. Surgical wounds. Teach patient about incisions. So you always want to look at the size, the location, the type of closure, the drains and the dressings. Okay. I don't think that it has it here, but I'm going to talk about it right here, right now. There's something called primary, secondary, and tertiary intention. Have we discussed that already?
Four stages.
Yeah. What chapter is that on?
It's in chapter 13, I think.
Okay.
Fundamental.
Go back to those and read them, okay? Because I don't know if it talks about them here, but we're still going to test you on that. Primary, secondary, and tertiary. Okay, remember those. All right. Pain. Again, we spoke about pain. I think you guys are good with pain, right? Non-traditional pain medication or analgesics would be cognitive behavioral medications or interventions, guided imagery, things like that. We have biofeedback, relaxation techniques. Traditional would be injections, PCA, epidural, oral analgesics. Again, what common complication do we have with opioids in general? Constipation and respiratory depression, in particular morphine, right? And then for epidurals, what's common with epidural? Hypotension. All right, let's move on. A couple of tubes after surgery. We have several tubes, guys. Every year, the manufacturing companies come up with new ones. The most common one that we use are some type of suction devices. Okay, the JP drain, a Jackson Pratt drain. Okay, you'll find this in the book. It's a tube, guys, that's attached to a little ball that looks like a grenade. It collapses because it's plastic, and you close the hole, and it develops a suction cup. Okay, the tube is inside the patient, in the wound or whatever, and it's constantly sucking out or aspirating all the contents of the drain of the surgical incision. It could be purulent drainage, anything like that. That drainage, guys, becomes part of your output for the patient. Write that down. That drainage becomes part of your output. Jackson Pratt. Jackson Pratt. Jackson like Michael, and Pratt like P-R-A-T-T. And that would be an example of your of a wound tube. It also talks about nasogastric tubes. What are the purposes of NG tubes, nasogastric tubes? Feeding and decompression of the abdomen. Write that down. Okay? NG tubes, it could be feeding or decompression of the abdomen. If a patient has a gastric ulcer, okay, or a peptic ulcer, mind you, they're called ulcers. It's a peptic ulcer if it's caused by pepsin, which is one of the chemicals in your stomach. A gastric is just a regular umbrella term. But sometimes your stomach's bleeding or something, you can do an NG tube and it decompresses the stomach. Or you're very gassy, it decompresses the stomach. Okay. Or if you OD, you give them charcoal and it decompresses the stomach. We can give charcoal. The properties of charcoal, it absorbs all the medications that will cause you to get sick, and it'll make you throw them up. They do that a lot in the ER. Okay. IV and of course oxygen tubes. Make sure that when you're dealing with patients, you make note of everywhere where they're at. Make sure we're going to talk about the signs and symptoms of infiltration and phlebitis and all that later down the road. Okay. Medications. Some medications that reduce anxiety. I think some of these we've discussed already. Valium for SED. Know those, please. Decreased anesthetic needed. Decreases the anesthetic needed. Excuse me. We could again Valium, morphine, and I think that meperidine is Demerol. Yeah, it's Demerol. So these medications that we can give to decrease the need of other stronger medications like the anesthetics. Now, we talked about anticholinergics again. What are anticholinergics?
The ones that don't give fluid.
Yeah, it decreases the fluids. Yeah. What's the most common one that I talked about? Atropine. Atropine is right there. If giving on nursing unit, use safety measures, bed in low position and side rails up, monitor every 15 to 30 minutes. The reason why the bed has to be at its lowest position is because this might kind of alter their cognition. They might jump out of bed, but if they're low in bed, they just fall 1 foot versus being high in bed. Okay? I spoke about general versus regional anesthesia, right? General is your whole body. General, or excuse me, localized or regional, it's only that specific place, that specific spot. Please know the difference, guys. Please know the difference between those two. A spinal block, guys, or an epidural is considered regional. And then local, topical application or infiltration into tissue of an anesthetic agent. So local and regional, guys, are pretty similar. Your regional is going to be your epidural. Local is going to be like a little shot of lidocaine anywhere to numb that specific area. I'm not gonna test you like on the differences between those two. Just know the difference between your general anesthesia and your local anesthesia. Okay. I spoke about conscious sedation. You guys remember what conscious sedation is? Okay, usually.
2 and 1.
Yeah, so bronchoscopy, the patient is awake, but they're sedated. And then we give them some medication, they'll forget what happened. Okay? The administration of drugs to depress the central nervous system provides analgesia. Primary uses, I spoke to you about that, bronchoscopy.
Yeah, I have a question.
Yes.
If they're awake and sedated, or if they're like awake and can't feel anything, why would they want them not to remember? Do they actually still?
That's a side effect of the medication.
Oh, it's just.
It's a side effect of the medication. Yeah, the medication that provides conscious sedation, that's a side effect. Makes you wonder about all the times that these dudes have assassinated other dudes, and they're like, I don't remember. That we can do that. We've been able to do that since the 40s, I think. All right, and advantages are, these are some advantages, guys. A patient goes under general anesthesia. We have to titrate or calibrate the drip of medication going into the body to put them out. We have to stabilize the vital signs. The anesthesiologist does this. And then we have to bring them back to consciousness. So that's a hard job to do because we're continuously, the nurse is continuously titrating the drip and everything. Versus conscious sedation, we just depress the central nervous system that acts in certain functions, but the patient's not passed out. I mean, the patient's still breathing on his or her own. The nervous system is still doing that. Okay, that's the advantage. We don't have to worry about the patient not coming back from the anesthesia. Some surgical procedures in the brain, they have to be awake because if they go to sleep, if we put them under and then we kind of we make a mistake or something in the surgical procedure, the patient won't wake up again. Okay, you guys ever seen Prison Break? Okay, I think on Prison Break they showed that. Yeah, I know that guy was gay. I know he was gay. He's a handsome guy. I'm just saying. I'm just saying. All right. Let's see. Preoperative checklist, guys. Read that up on your own. Okay, just read all that. Make sure that if the patient has dentures, you remove them because they might aspirate on them. Remove jewelry. Excuse me. Okay. Eliminating errors. This one's really important. Okay, wrong site, wrong procedure. 3 times during surgery, they do a check to see if the patient actually, if it's the correct limb, if all the tools that we utilize for surgery are accounted for. And we have a scrub nurse, an OR tech. We have different nurses that do all of this. Okay, you guys can read that on your own. I'm not going to test you on that. But the Joint Commission guidelines to prevent errors, it talks about a pre-operative verification, site marking, and verification by surgical team members during a timeout. So literally right before surgery begins, they do timeout, and we count again all the instruments. Make sure that the right leg is the right leg. Make sure it's the right patient. Okay, make sure it's the right patient. Imagine, ladies, you guys are going in for a mastectomy because you guys had some type of breast cancer, and you come back, you wake up, and you realize that they removed the wrong breast. Okay, that's a big issue.
I would sue them.
I would sue them as well.
You might get some brand new nice ones.
Exactly.
Okay. All right, transportation to the operating room. Compare IDs to bracelets to the medical record. Assist patient to stretcher. Direct family to appropriate waiting area. You could read a little bit more on that, guys. All right, preparing for the post-operative patient, meaning after the patient comes back. There's a whole list of things that we need. Essentially, guys, those of you that are CNAs are probably a little well versed in this. When the patient's going to come in, you set the bed up, right? You make sure that the patient has, at acute hospitals, make sure that the IV pole is there, the BP cuff. That's what I'm referring to. How high or how low is the bed when you're getting a new patient? No, guys, when the patient's coming in at its highest position. All only the side rails on the side are up. Okay? Or sometimes they put, depending on the policy, all side rails down. Because the patient's stretcher is high, right? When they're coming in from the from the ambulance. If you work at convalescent homes, it's different. I see where you guys were going with that. But again, new patient coming in, make sure the bed's high, all that good stuff. Whenever you leave a patient's side, how should the bed be? At its lowest position, and the call light has to be next to them, okay? A sphygmomanometer. What's a sphygmomanometer? Okay, good. No, it's a blood pressure cuff. A sphygmomanometer, yeah. Then the stethoscope is a stethoscope. Okay, thermometer, Emerson basin in case you're gonna vomit, clean gown, washcloth, towel, tissues, IV pull pump, all that good stuff. Okay, guys? Yes.
In the real world,
Yes.
are we gonna have to run around to find a thermometer and find some gloves?
If you guys
or
work-
is it just certain facilities that are really low on their budget? Because it seems like a lot of running around.
At convalescent homes, it's gonna be more real world. At hospitals, at acute hospital settings, it's what it says.
Okay, good.
You have to have
I was
everything.
gonna have to buy all kinds of stuff.
No, yeah, you do have to provide all these. At the hospitals, you have to provide all that. But the hospital has them. The hospital has everything. If you work at a decent hospital, it has everything. Bless you. All right, holding area, the pre-anesthesia care unit, that's also known as PCU, okay, guys? So write that down. You're going to see PCU unit in your reading and in the exam. Don't be confused. The pre-anesthesia care unit. Okay, let's see. Let's talk about the role of the nurse. Guys, it talks about a circulating nurse, talks about the sponge nurse, the scrub nurse, all that good stuff. I'm not going to go into that. I'm not testing you on that. But read it, okay? Let's go to page on the PowerPoint. Let's go to page 11. Alright, so post-op, guys, any patient post-op, we assess vital signs. It's the first thing we assess. You want to assess vital signs, you want to assess the IV, make sure it's patency, meaning make sure that there's the patient can actually have medications inserted if needed. You want to assess the incisional sites, tubes, post-operative orders. Physician might have ordered some specific medications. Body system assessment. Side rails up, and you want to have the call light in reach. Okay. Continuing, you want to have the head of the bed up 45 degrees, Emerson basin at bedside, all that good stuff. Let's talk about incisions. Okay. When it comes to the dressing, guys, any type of incision that you had, you assess the dressing, the gauze. What type of drainage do we have?
Serious.
You have serous, which is fluid, clear fluid. Sanguinous, which is what? Bloody with clots and everything. And serosanguinous, which is a mixture of both. Okay. Please be able to identify those. Let's talk about dehiscence, however you want to pronounce it, and evisceration. These two you have to know. They're really important for you to know. Surgical incision, guys, usually we staple them shut now. It's easier. If I have too much, if I provide too much abdominal pressure, the surgical wound may open up. That's dehiscence. Okay. If it gets worse, you can have something called evisceration. Evisceration by definition, it's a protruding of the internal organs coming outside of the body. How do you treat that? You get a sterile saline gauze. Okay, make sure it's wet. You place it on top of the patient's stomach, and you call the doctor. It's an emergency. Okay, you'll hear a lot of literature about you put the patient in a Fowler's position. You make sure that they're lying flat. Whatever position they're in, you leave them in that position. Typically, though, you're gonna want the patient to be flat. Okay, you put the patient flat. You cover it up with saline gauze, and you call the doctor. Any questions on how to treat that?
Yeah, what if they become hysterical and they won't like still? Can you order something? I can do that too.
If they become hysterical?
If they become hysterical and there's not a doctor around to ask if he can give something, you still can't give him anything.
Well, no. I mean, what I'm saying is the patient's going to wait there for a while. The patient, it's not like the doctor's going to be on the floor. No, you call the doctor. You guys ever page a doctor?
Yeah.
You call a doctor, you page them. First, you find the number that's working. You page the doctor, you get through the receptionist, you call him or her, they send the message, then you wait till he calls back. Mind you, there's a chain of command that you go through if it's an emergency, or you can call another doctor that's in his, what was that? What do you do if they You keep the intestines moist and sterile to prepare for surgery. If the patient becomes hysterical, I can tell you that I've been there, so I could probably, I won't slap him just yet, but I'll probably be able to calm him down. If you're a novice, if you haven't done this before, yeah, you're gonna find yourself, you're gonna freak out too. You're like, oh my God, you're gonna die. But you try to reassure them. The best thing is you have to be cool, calm, and collected. Like, man, this happens. I know how to treat it. I'm okay. Mr. H taught me. I got this. Okay? Yes.
What if they're like ambulating or something and they're...
Yeah, I was gonna ask
Okay.
that.
If it eviscerates while they're ambulating, you want to sit them down as soon as possible. Okay, but what takes priority? What's the whole purpose of this? You want to maintain the integrity of the intestines. So you find that gauze, you find a chair, you apply it over them, and you have them sit down. Okay, that's what you do.
And then slap him if they
And then smack, yeah. And also, guys, there's certain restrictions on what you can and cannot do post-operatively. So if the patient has a fresh wound, they're not going to be walking around ambulating. They're going to wait a couple of days after the surgery in order for them to prevent such a thing.
Yeah, well, the C-section and take it to the next day.
The C-section is a very small incision. Okay, it's like that big. No,
I saw my mom.
that big? That's back in the day, guys.
Well, small.
Depends on your kid.
Okay. Yeah, I don't know. All right, let's finish this up, guys. We're almost done. We have 10 minutes left. So please know the difference between your dehiscence and your evisceration. That's a little illustration of both. Please know them. Please know how to treat them, okay? It talks about it right here. Cover with a towel moist with sterile saline. Have a patient flex knees slightly and put in a phallus position. You see how some literature says certain things? Okay? I disagree with that. You're increasing the pressure in the stomach. I feel like it's going to come out more. But their whole rationale is you want to increase the pressure to keep everything inside. I disagree with that. Literature says both. Okay? My advice is supine, sterile saline, or it says towel, but you want to use gauze, something that's sterile.
What about the home test? What you said?
Well, I just told you right now. Laying flat. Okay. What have you anyway. All right. Let's see. All right, so I want you guys to understand the whole concept that analgesics, opioids decrease the respirations, the respiratory tract. Okay, a couple of other things that will hinder the ventilation of a patient would be the following: drugs, again, opioids, the incisional pain. If a patient's in prolonged pain, okay, every time they breathe in and out, their chest is expanding and contracting, right? So that's going to hurt. So are they going to be breathing adequately? They're going to be doing this. Okay, so it's going to change their ventilation as well. Obesity, chronic lung disease like COPD, which we'll talk about in a few weeks, and pressure on the diaphragm as well. You can have atelectasis and also pneumonia.
Atelectasis being the lung collapse.
Lung collapse, yeah. It's when you guys see it in your book, it'll say an abnormal expansion of the lung. It's a lung collapse. Okay, the lung's not expanding all the way; it's collapsed. Let me see. Again, we prevent these things by turning and repositioning, coughing, deep breathing. How long do we inhale for the incentive spirometer? 8 to 10 seconds. Okay. You guys remember the signs and symptoms of a pulmonary embolism, right?
Warm. Oh, the pulmonary.
Yeah, pulmonary embolism. Shortness of breath, sharp pain in the chest, dyspnea, hemoptysis. Okay, please remember those. Here are some other signs and symptoms of pulmonary embolisms. Okay, it says signs and symptoms include sudden chest pain, dyspnea, tachycardia, cyanosis, diaphoresis, and hypotension. Okay, nursing intervention would be keep the head of the bed up 45 degrees, apply O2 max, 100% O2, and increase the liters up to 15 liters or whatever the max allows you, and notify physician. It's an emergency. The patient will die if not treated. Okay, let's see, post-operative, later post-operative phase for pain management. You offer analgesics every 3 to 4 hours. Acute pain, the first 24 to 48 hours, you offer medication. The patient will have that. Methods of medication administration just really depends. What's it going to be, guys? What do you think? Post-op, IV or oral? IV, folks. IV
IV because this guy.
Because we don't know. Yeah, and it's also usually post-op. You have your acute pain. Okay, the patient is known of having chronic pain. Then yeah, you give them oral medication, but that would be not during surgery, not before or after surgery. Another type of way to treat pain would be the TENS unit that we just went over in chapter 16. Let me see. You want to assess urinary function at least every 2 hours, and you assess for distension. Okay, you palpate. That's how you notice. You palpate the suprapubic area. What happens if the patient is retaining urine? What can you do?
Catheter?
Catheter, Foley catheter. It says measures to promote urination: running water, hands in warm water, ambulate to bathroom, male stand to void. Okay. Accurate intake and output 30 mLs per hour minimum. That's what I was talking about. Okay, guys. Okay, we spoke about venous stasis already. We talked about TED hose and all that good stuff. Let's move on. Skip that first box. Okay, I want you guys to see this. On the GI status, it talks about 3 to 4 days for bowel activity to return. Please be aware of that. So if you have a patient that's post-op, and on their second day post-op, they have had no bowel movement, what are you going to do? It's typical, right? It's expected. If it's been 6 days, no BM. Okay. Potential complications: paralytic ileus. What does paralytic mean? Pertaining to paralyzing, right? Ileus, guys, is going to be an obstruction. An obstruction. Please know what that is. Your paralytic ileus, or ileus in general. It's an obstruction. Okay, it's going to be a decrease or absence of peristalsis. And how do you manage that? Ambulation, fluid increase, okay, things of that nature. Constipation, usually 2 to 3 days after solid foods are started, patients should have stool. Okay, please read up on that. You can give a suppository or tap water enema, but it's going to be after that third day, because we're expecting the patient to be constipated and not having normal GI function up until that time. Singultus, also known as hiccup. It's an involuntary contraction of the diaphragm followed by rapid closure of the glottis. Irritation to the phrenic nerve. Causes could be abdominal distension or internal bleeding. If you suspect a patient having an ulcer, guys, whether it's a peptic ulcer, whether it's a gastric ulcer, any type of ulcer, okay, how can you detect if the patient is bleeding or not? What are you going to expect? If I'm bleeding from my ulcer, what's my stomach going to look like? It's going to be distended, so please know that. Okay, abdominal distension for any type of gastric ulcers. Abdominal distension for any gastric ulcers or peptic ulcers, it doesn't matter. But you're going to have distended abdomen. Also, before any type of before surgery, guys. I'm sorry, I forgot to talk about this. Before any surgical procedure that's GI, okay, you want to have the patient empty out their bladder. You want to have them stand up and go urinate, because if the bladder's full, if you're performing a surgical procedure in the stomach, you might nick the actual bladder, and now you're going to have a whole other set of issues. So make sure. Excuse me?
Would they put a catheter in once you're in the operating room?
Yes, they would. But it's also recommended before the patient actually goes into surgery to walk up and go urinate, to go void. So please remember that, okay, guys? That's going to be on the test. Okay? All right. Let's see. Fluids and electrolytes. Anytime a patient vomits or anytime a patient has diarrhea, their electrolytes are going to be depleted. So how do you compensate for that? You give them more fluids. You give them some type of fluid. Yeah. Okay. Know what insensible means. Insensible fluid loss. It's usually when you're breathing. You know, if you put your breath on the window, you see the condensation. That's what it's talking about. Okay, and also through skin. Sodium and potassium depletion occurs with blood loss, fluid volume loss. Please know this, guys. So the patient has an NG tube, okay, hooked up to suctioning, or for the purpose of decompression. One of the risks is an electrolyte imbalance, usually potassium, depletion of potassium. Okay. Know what catabolism means? Is tissue breakdown from severe trauma or crush injuries. And that's pretty much it, folks. Okay, sorry for the boring lecture. I just figured this way we would get over it. Hold on, I have something to pass out.